Right, I think we should probably make a start.
Yep, sure.
If that's okay. So, good morning, everybody. My name's Jo Hargrave. I'm the lead midwife for the East GMSA. I think I know a few of your faces, but not everybody. But thank you so much for joining us for this midway point update for the prenatal exome sequencing project. If you just want to go to the next slide, please, Lauren. So just to remind you that this session is being recorded for those that can't attend today. So it's really important if we are having discussions not to disclose any patient identifiable data. And next slide. And also, if you have any technical issues, apparently get in touch with me, although I'm not really tech savvy. So good luck with that one. I think from what I can see on the call, a lot of you are aware of the GMSA. So if you don't, it stands for the Genomic Medicine Service Alliance. And there are 7 across the UK. And the idea of it is to ensure that all eligible patients can benefit from approved genomic tests when required. Next slide, please. And we also work alongside the laboratory hubs, which provide coordinate genomic tests within the region. And these tests are commissioned and set out by the National Genomic Testing Directory, and it's trying to reduce that postcode lottery for testing and to ensure that there is high quality and personalised testing and care for patients. Next slide, please. And this is our area. So we cover a massive area in the east. So it's the East Midlands and the east of England. Next slide, please. And this is the wonderful team. And I'm going to hand over to Kasia and Lauren shortly, but I just wanted to sort of shout out and say many thanks to Katie, Melissa and Fleur for their work as part of this project. As there's not loads of people on the call, it would be really helpful if we could just go around the room and introduce ourselves, and just to get an idea of where you work and what your role is in terms of the R21 and how it affects your role. So I'm going to try and I'll start with Rebecca because I can see your face first of all.
Hello, my name's Becky. I'm one of the fetal medicine midwives at the Norfolk and Norwich Hospital. So yes, we have patients who come through who have obviously babies with multiple anomalies who are then suitable for R21. So I'm involved in that sort of pathway, that part of it.
Thank you, Becky. Victoria Black.
Yeah, hi, I'm one of the screening midwives at Northwest Anglia. So we've recently started sort of handing a lot of our fetal medicine and genetics work over now to a fetal medicine midwife, but still sort of involved in that collaboratively during that handover period.
Vicky Carr.
Hi everyone, I'm the lead nurse working in the GMSA with Jo.
Thank you. And then I've got Kathy. Sorry, Kathy, I don't have your surname.
Hi, I'm the lead midwife for the antenatal clinic at the West Suffolk, and I was just asked to attend by our screening midwife because we refer a lot to fetal medicine as well.
Lovely, thank you, Kathy. And then I've got a group under fetal care.
Hello, we're the fetal care midwives at City Hospital in Nottingham, and we work cross-site at QMC as well.
Perfect, thank you for coming. Sarah Logan.
I'm the new fetal medicine midwife at Northwest Anglia. So I'll be taking on the genetics from the screening team, like Vicky Black said. So yeah, needing to learn more about it, basically.
Fabulous, we're in the right place. Maz O'Reilly.
Hi, I'm Maz. I'm the lead genetic counsellor at Nottingham.
Thanks for joining. And Jessica Myring.
Hi, yeah, nice to see you all. My name's Jess and I'm based in Leicester in the genetics team there, and I'm responsible for prenatal which of course more and more so is involving our fetal midwives here as well. So yeah, happy to hear what everyone else is doing around the region.
Fabulous. Oh, Kirsty, you don't have a microphone, but welcome and thank you for letting us know. So screening midwife, and then Tate Haplin, fetal medicine midwife, and Claire Barwell, screening coordinator. What's I'm not very good with these. What's NWAFT? Which trust is that? Lauren, help me out here.
Northwest Anglia. Is that?
There you go, Northwest Anglia. Thank you. So you can tell my geography's not fully there yet. Melissa?
Hi, I'm Melissa Campbell-Kelly. I'm an associate nurse with the East GMSA and I'm based at the North Norwich Hospital.
And then Fleur?
Hello, yes, I'm lead midwife in fetal medicine at the Roses, and I counsel and consent women for R21 on almost a daily basis now.
Fantastic, that's good to hear. Thanks, Fleur. And then I think finally, if I haven't missed anyone, I've got Carolyn Ramsdale.
That's me. Yes, I'm a screening midwife and I'm based at Sherwood Forest Hospitals, just right at the very top of your area.
Lovely. Thank you so much for joining. Have I missed anyone? No, I will then briefly hand over to Kasia then, because I think it's very important that that she says hello and welcomes to the project. So I'll hand over to you, Kasia.
Good morning. My name is Kasia, I'm one of the fetal medicine consultants in Cambridge, and I'm leading together with my colleagues here on this project. The project was born out of experience with fetal medicine patients at CUH, whom we realized that very much dependent how the patients were managed from where they lived and where they initially went to have their care. And then we realized that we are not alone, and the other regions, other hospitals are in the same shoes. And we started thinking how we can change it in this very changing landscape where we have more and more new facilities in terms of genomic testing, and how we can make sure that every patient who really is eligible for this is receiving appropriate care. There are newer and newer tests, and these tests are fantastic, but they are only as fantastic as they can get to the right patients. And the session today, we are very grateful that you are joining, because really this session we would love to have as interactive, and we would love you to have as much input to this and as many comments as possible with regards to the findings from the project so far. I'll hand over to Lauren, and she'll be presenting what we did, how we basically how we planned this project, and what the outcomes so far are.
Thanks, Kasia. So I'm Lauren, I'm leading on this project, and I also work as a fetal medicine midwife at a secondary centre. So that's kind of my background. So we'll fly into today's aims. So we want to provide you with an overview of the project and what sort of the interesting data that we've found so far, discuss some of the clinical resources that we've kind of developed or in development to support the delivery of R21 testing, and also consider ways we can improve the way that the delivery of the genomics is being led in prenatal services. So if you have any questions along the way, please either pop your hand up or interrupt me. I'm happy to be interrupted if I'm not explaining something, or you have a question about something that I'm talking about, or you can leave it to the end, or just pop something in the comments. It's absolutely fine. So the aims of our project I'll run through here. You've your units would have been involved in the self-reporting questionnaire that we sent out back in October, November time, and that was really to map out where all the units were, which services they were providing, and who they were referring to. And it was a really interesting piece of work, and I appreciate it took units quite a lot of time to fill out, and actually some of the data we were asking for was challenging to get. So we really appreciate the time that you spent to do that. So we were looking at team structure and also stakeholder engagement. So that's how we work as MDTs and as professionals together, looking at how busy we are in terms of what testing is being done at each unit, also what support we provide for patients and families, and also training needs, if there's any training needs that are identified in terms of the R21 testing. And then from that data, we've been looking at it, and we're still kind of looking at it, but initially we're looking at sort of a strategic approach to improve the equity of testing, to ensure that everybody that needs a test gets offered a test in the right way, and develop some resources and recommendations to support that moving forward. So what have we found so far? This is our region, and I know you've seen this map already today, but what I've done is I removed the units that aren't maternity units. On here are all the maternity units in the region that are served by the East GMSA region. So there's 16 in total. There are 4 tertiary units. There's a secondary unit that has outreach from a tertiary centre that goes to that unit. That's in Kettering, and that's serviced by Leicester Fetal Medicine. There are also 6 secondary fetal medicine units that also refer to tertiary centres for more complex cases. And then there are 5 maternity units without a fetal medicine unit. And I think there's quite a few on the call today of those units. And we really appreciate the work that you do, because there's a lot of liaising, there's a lot of supporting of those families that are being referred out to other centres and supporting them through that journey. And that's a really key part of the pathway that I don't know if we're going to touch on as much as we should do within this presentation, because we're really sort of focusing on that delivery of the R21, but all of these things are really important for you to still kind of understand how they work and be a part of. So I hope that you feel like we acknowledge the hard work that you do, because we know you do it. So thank you. So all of the samples from these units, when they send R21s, they all go to GOSH. There are two laboratories that look at the R21. There's one in Birmingham and GOSH, but these all get referred to GOSH. So first of all, we looked at team structure, and this was just to see how the teams are put together in each individual unit. So this is a busy slide. I will take you through kind of the interesting points on it. You don't need to fully understand it and grasp all the information, but it demonstrates nicely how the units are staffed quite differently. There isn't really no unit that's the same. Along the side, you've got the name of the hospitals. The 4 hospitals at the bottom are the tertiary units, and the ones at the top are the secondary units. And under, I've put a rough estimate of the births per year, so we can see maybe the activity of that particular unit in terms of birth. And I know it's not necessarily completely reflective of tertiary centres where they're receiving referrals in, but it gives us a gauge of how busy are those units. So in the blue, we've got the consultants, and I've put it as staff members rather than part-time, because we didn't quite get the data as we wanted. Oh, yeah, stop me.
Sorry.
Oh,
I'm not seeing it. Sorry, I'm not seeing it in colour. Is it my end or your end? Is everyone else seeing it in colour?
Yeah, I can see it in colour. Yeah.
I'm fine. I'll do something in my end then. No, I'll sort it.
Where it says a PAs, that's your consultant box there. So we're looking at that one at the moment. So these are PAs are program activity, and a term used for consultants for blocks of time, like 4 hours worth of time, and they're generally used for like a scan clinic. So you can see here there's quite a range of the number of PAs that are provided at different units, and the staffing to do with that is just really interesting. And we haven't fully kind of got to the bottom of the data, but you can see how you can understand the busier units like Leicester with 11,000 births have 19 PAs, and you can understand the reason why, and maybe why it appears they've got more staff. Interestingly, I think also you can see there's 19 periods at Addenbrooke's, and it's a very busy hospital, but their births are lower, but they have more referrals from, I think, secondary units and other units around them. So it's trying to understand that in more depth. I think it's really interesting. If we're looking at fetal medicine midwives, so we've got the non-rotational midwives in grey, and sorry, Jess, if you've not got the colour, that's not going to help you. Some units don't appear to have non-rotational midwives, so fetal medicine, dedicated fetal medicine midwives, and maybe there is an impact of not having that skill set on how that services are delivered, and that's something that maybe will be explored with those individual departments. So yes, I remember you saying Northwest Anglia now have a fetal medicine midwife, so I will update my my slide with that. Thank you for that. I'll remember to do that later. So
Lauren, just for my help, which are the fetal medicine midwives in your diagram here?
yeah, so
Is
if
that the
you look,
non-rotational?
non-rotational, yeah. And then have you got colour now, Jess? Okay. Yeah, great. So does anyone have any sort of comments on this slide? Any thoughts on kind of if it made sense, or what struck you about any of this really before I move on? Nope.
I think the fact that there are units which the midwives rotate between fetal medicine and other parts, because fetal medicine, obviously, it is a quite different place from other settings within obstetrics. So that's require not only slightly different skill set, but also from our experience from CUH, not every midwife likes being in fetal medicine. So this is really quite a sort of different group of midwives who would like to work there and have this skill set. Sorry, Jess.
Yeah, no, so, you know, it's very striking, this diagram for me, and I won't bore you with all my thoughts on it because, of course, Leicester is my place when I'm trying to get genomics into midwifery wholeheartedly, but coming across a lot of stumbling blocks. And I think it is intrinsically linked to the fact that I have no non-rotational midwives or fetal medicine midwives here. And this diagram is so, I mean, that's very obvious, isn't it? Mm. So very helpful for me and represents exactly the problems that I feel like we are facing in implementing good quality fetal genomics, fetal medicine genomics.
Thanks, Jess. Yes, that's the
I mean,
interesting thing.
There's no midwives on the call from Leicester today.
Yes. I think it's very interesting, and to be able to look at all the different units and learn from different ways of doing things as well. And I think that's one of the exciting things about doing this project, and the results from this project hopefully will move forward with more sort of collaborative approach and be able to learn how to do things better all together, because you might have some things that you'll share that other people don't do that will be useful, and vice versa. So thank you. So here we're just looking at the differences in allocated time for appointments per unit. And I thought this was quite interesting, the variance between the times. And I wondered why it was. I don't have the answers. You can see the tertiary units on the left-hand side. Most of the tertiary units will have a 60-minute initial appointment, and I can understand why they need that. And I think that's right. I think having more appointment time, I would imagine, will be better, especially if we're talking about R21 and the complexities that are involved in that process and discussing with families. I guess for me, it's a little concerning when we look at Leicester that they have 30-minute slots, but maybe they have other arrangements around how they deliver services that means that they do that in a different way. So unpicking those would be useful. And then the follow-up appointments generally on majority are 30 minutes, and you can understand this because they've initially done those the bigger conversations, so it's just following up. So I would understand why most of them would be a 30-minute slot, but there is a variation within that where there is flexible time. For example, Bedford, actually, they've said here between an hour and 45 minutes for both appointments. They will be able to do that, and in East Suffolk as well have a 45-minute appointment for both. So again, I wondered what you guys thought about the differences in time and what you see and experience at your units, whether or not you feel like you have enough time to counsel patients appropriately, if you feel rushed, if the reason that your appointments are shorter because you're trying to fit a lot of extra scan slots in and that's the way that you're doing it, is it a capacity issue, that kind of thing. So I kind of wanted to use this to maybe tease out some of that information if you were able to share that with me. Anyone?
Hi, it's Becky at Norfolk
Hi,
and Norwich. Hi. So with our appointments for our new referrals, which are, like you say, 40 minutes, I think it depends on what the patient's coming in with, because some things will take longer than others. So our clinics tend to obviously have a range of things in them. So I think it doesn't feel rushed. It feels a lot of the time majority of the time we are running on time. So I think, yeah, for 40 minutes appointments, it works okay for us. And things like if a patient then needs some blood tests afterwards, usually there's like myself and my colleague in the team. So then the other midwife can take the blood samples out of the clinic room, and then you can carry on with the next patient. So it works quite well because we are quite a small team here and we sort of help each other. And there's normally 2 fetal medicine midwives in on a one day. Obviously, when there's not, that's a little bit more challenging, and we probably do need a little bit longer. But it also depends on what's coming, to that appointment, in terms of sometimes you have someone that comes for one thing and then you find lots of things, but it sort of balances itself out, I think. And with the follow-up appointments, we have an afternoon clinic, which are 30-minute appointments, and they tend to be the follow-ups. So they tend to be a little bit shorter, so we can see more ladies, and that's once a week in the afternoon.
Right, thank you for that. Jess? Oh, sorry, Fleur.
No, sorry. I was just saying, well, we have hourly appointments for all our new patients and a half hour for follow-up. And the consultants are adamant that they actually need that hour with 99% of the patients, because you can't have these in-depth conversations and counsel people and give them informed consent in in a rushed manner. And because we're a tertiary unit, we're often getting the patients that need extra input, and they are making life-changing decisions which can't be done in a rush. So in half-hour appointments for a new patient, I think we'd really struggle to give a decent service.
Yeah, thank you. I think, was it Jess next?
Yeah, can I just do a couple of quick checks with you, Lauren? This is R21 timings, right?
Just general clinic appointment timings,
okay.
We didn't specify.
Okay, so this is just, okay. And from the data from Leicester, did you get it from a mixture of different consultants, or did it come from one consultant?
No, that was just the one consultant. That was just from the self-reporting questionnaire.
Because my guess is that there'll be a lot of differences depending on who you talk to in Leicester. There are 2 different main sites and the teams work quite independently, and there's lack of crosstalk. So I think I have no idea whether that's even accurate.
Okay.
So I think it's worth noting that, because yeah, it would very much depend on who you spoke to.
Right. And I think it was Kasia.
I just very briefly add something to what Fleur said. In this timing, what is not counted for Cambridge is pretty much midwife's time is not counted here. So what we do, we would scan and cancel the patient, and we usually would stay with healthcare assistant or with the midwife, but then there will be second midwife who would actually discuss this with the patient in the separate room. So not all the time, particularly if this is with R21 or some more sort of complex things which the patient needs to have more time. And this actually came to me just now, that within this, the time for the midwife isn't counted.
And then I've got fetal, I think it's fetal care as well, that have their hand up.
Yeah, so we would agree with that comment in that we're a tertiary unit as well, and we certainly need an hour for an initial consultation. And we tend to find sometimes that we do need more than half an hour, but they're only allocated half an hour for any follow-up appointments. And it depends on the complexity of the patient. Certainly, as previous people have said, certainly with R21s, there's a lot more involved in terms of midwifery input after that initial appointment with the consultant as well. So I think that's important to take into consideration.
Yeah. Is there anyone I've missed in terms of hands up? Do we have a legacy hand? I have a hand in still in fetal care, I think. I'm happy to move on if you are. Perfect, thanks. Thank you for that. It's really interesting to actually kind of get some more depth to what we were finding from the questionnaire, so thank you. So moving on, we're looking at acuity, so the acuity of the testing. Oops, I'm sorry, computer had a bit of hiccup. Right, so this is a graph which is showing the genetic and genomic testing for fetal abnormalities. So recorded acuity for the time frame April 2021 to March 2022. Again, apologies, is a bit complex, but I'll talk you through sort of the things that I feel like are useful to kind of take from this, or things that I would like some sort of more thoughts around. So in your orange, you've got the number of microarrays during that time. And then we've got in yellow the number of R21s accepted, and that's been reported by units. So the individual units from the self-reporting questionnaires. And then in green, we've got the number of R21s requested by GOSH. So I asked for the data from GOSH and they gave it to me in this requested format, and they weren't able to give it to me in the same format as what they accepted, unfortunately. So I'm kind of comparing apples and oranges, and I'm sorry for that, but I still think we can kind of take some take-homes from it. Just to point out that Leicester Hospital's date range for their R21s was from December 2020 to 22, and that was just because the way that they gathered their data at the time, and some of the other units didn't actually have that data. And I think everybody found it quite challenging to gather this data for us. It was quite a lengthy process for people, and I think that just identified that perhaps we could develop a way that we could maybe have a spreadsheet that people could use, a straightforward spreadsheet, not a time-consuming one, that everybody could use to report really important data in terms of these. So then we can easily feed back and we can kind of see what's been requested, what's been rejected, what the findings were, if there weren't any findings, and it would really support possibly in the future when maybe KPIs come into place in around the R21, that we'll already have this data and be happy to be starting to complete it. Jess, do you have a question?
I just wanted to second that, because I think, you know, my feeling is that the Express study has collected data at their end, and a real oversight has been the collection of data at our end, because it's a cross-departmental responsibility to some extent, and been tricky, certainly in Leicester, to get different people to do it, you know, across 2 different sites. So I think it's a real pity that we don't have that data. And as you know, Lauren, we've been collecting it, and we now are collecting that, because otherwise we can't say what's actually happening on the ground at all. So I think that's right. I think you need to, you know, we're very happy to share that, the data that we're collecting, or the spreadsheet that we've got, if it helps other people.
Thank you. Kasia?
I think this slide actually is a quite important output from the questionnaire, because it just shows that it is pretty impossible to get accurate data at the current time. And this itself is quite a nice piece of work which we all can do to help and make some form of streamlined and stratified collection data for microarrays and R21 overall, what in terms of genetics is happening with our patients.
And Fleur? Or your
So when I was doing this questionnaire, I think this was one of the most important things that came out of it, that there was no one way that people were collecting the information. And I think one of the things that really needs to be done ASAP, and it's a pity it wasn't done before R21s came out, that there were KPIs and a method of collecting the information, that everybody was collecting the same thing so that it could be compared, and then people would see there would be a natural pathway if there was that framework in place.
Yeah.
We're just about to do an audit now. We're just about to put our audit together, our internal one. So we'll let you know.
But also then we can see easily actually how not only how many patients we sent, but also what happened. Did we send and what the reply was, which cases we had which actually did not fulfill criteria and were turned down, what then happened to this patient, what the outcome for the baby was. So I think this will be also beneficial to actually see the pathway and how actually we are helping particular patients.
Yeah, I mean, what we're doing at the moment is time frames, so how long it's taking, basically outcome data to say what actually happened, so we can capture how many end in TOPs and then never go ahead or whatever else it might be. And also just how that cross communication is happening as well, because those are our three main trigger points really. With
really very interesting to see what you find, and I wonder how much that will differ from the others. I suppose it will not differ much.
Okay, we'll move forward on to some of the resources that we've developed to support the clinical environment, really. So thinking about the challenges with R21 testing, and I think that probably most people would find the test directory not the most easiest document to read and interpret. So I put a copy of it. Sorry, it's a bit fuzzy. I couldn't get it to not be fuzzy. And it's just to show it there. And what we've developed is sort of a quick reference guide for clinic, and I envisage this being sort of like an A4 laminated two-sided document, which you can have a look at what the abnormalities that you're seeing or anomalies that you're seeing and be able to see where they fit into the inclusion criteria, if they do, what the exclusions within those inclusion criteria can be, because again, there are nuances to it. And just help the clinician to be able to make those decisions within the time frame, hopefully of sort of that clinic appointment, so that they can counsel patients appropriately and timely. So I'll move on to just show that first page. I don't know if we did send it out, so I'm not sure if anyone had a chance to have a little bit of a mull over. But don't worry if you didn't. But initial thoughts, I'm just really interested to see whether or not you find it a useful thing to have. If things strike you here, like the good, the bad, and the ugly, what you don't like, it's really useful to have some feedback so we can develop this. So Jess, I think you've got your hand up.
So it's wonderful, and I have to literally stop the fetal medicine team from just stealing it and starting to use it. So congratulations in the first place. My only other comment is, because I would like to do a detailed read through, and I'm happy to feed back to you, Lauren. Is red and green for colourblind is not great.
True.
Just to set, so maybe think about the colours, but apart from that, I love it.
Yeah. Fantastic. Good point. Does anybody else have any thoughts on this? Would it be useful for your departments, do you think? Yeah, thumbs up. Nice. Okay, fetal care.
Yes, it looks really good. I think we'd really appreciate it. It's good just to have a look at during clinic.
Yeah. And I think also for units that are referring on to secondary, or even, you know, the screening midwives, to be aware of this for when they're counselling patients, to refer them out. If they have an idea of maybe what they're seeing of the abnormalities when they're initially counselling, they can maybe think about discussing the other conversations that might be coming sort of the patient's way, and that's really useful to prepare them for these possible conversations, so that when they get there they have an idea of what all this means and they can start to process that. So I think it affects us all, even though we might not be using it within the clinic. It's still quite a useful kind of document to have. Saying that, we do need to make sure we keep it up to date. They regularly update the test directory, and it's not always obvious that they've done that. So within that top there, that you need to always sort of double check with the test directory, just as kind of like a fail safe. But obviously, as new things get introduced, there would be probably another version of this that would be extended. And then I've just got the back on here, which also has QR codes and links to the resources, the paperwork resources that you might need. So that's just kind of just aid if you haven't got a resource and you need to get it quickly, that you can go and just get it quickly rather than having to trawl through trying to find what you need. So that's that. Okay, so I think we've got general thumbs up. Nobody doesn't like it, thinks it's rubbish. Right, perfect, good. And then we are working, this is very much in principle, a generic workflow for the R21 pathway. Within this, we kind of wanted to put something together which outlines the steps that you kind of need to take in order to successfully request a sample. And I've left spaces for you to adapt it to your particular trust with the numbers you might want to call, or the emails and things, so that I envisage this again being something that you can print off and personalize and then laminate, so you've got that in your clinic as a process for people if they're not necessarily doing it very often, or if it's then new to your area and they're learning how to do it, just an aid for them to do that. So this still needs work. It's not quite there yet. And what we would want to also do is something similar for the workflow for giving results. And that I haven't started to put that together yet. But I think, again, that's something that's really useful when we're thinking about giving results, how we give results. And so perhaps we start to reduce some of the inequities by putting some framework around how that's done. So that's the idea. So again, if I could have any feedback, that would be wonderful. But don't worry if you don't have any feedback.
Lauren, just to let you know, we've got 10 minutes left.
Thank you. I think we should be okay. Sarah.
Hi, yeah, thank you. Just a very basic question. I can see that it says about patient information leaflet. Is there a leaflet already available, or is that something on the way?
So some units are using the North Thames original one, which is very wordy and not my favorite thing. And I'll be coming to this in a minute, but it's something that we're looking to develop, something that is, we would like to have a working group of people, so we get something that's really good for a patient information leaflet that's easy read, that takes them through the pathway. So I'll come on to that, but good question. And yes.
Thank you.
Okay, so counselling and consenting. I'm going to zip through this because we do only have 10 minutes. I just wanted to show how midwives are really skilled at explaining genetic testing for patients, and that's obvious here. You can see that collaboratively we're all talking about genetics in general. Along the fetal medicine pathway. Where it seems to drop off is when we're consenting for the R21, it's sort of predominantly the consultants, and maybe it's because it's consent, and that sort of ties into the reasons why it's fallen to that, and also the genetic service as well for a few secondary centres that have sent R21s as well. But as we can see, we've got Fleur here today, which is amazing, and she's doing the consenting in the R21, and hopefully we'll be working with her to maybe help some other midwives gain the skills to be able to also be involved in R21 consent, because actually that's going to support continuity of care and the patient experience and all those sorts of things that are really important. The reason why we come to work in the morning, isn't it? So And then in terms of who gives results, that's to be expected. It's multidisciplinary. It would be lovely if midwives, maybe they are more involved, but they didn't necessarily say that in the self fulfilling questionnaires. But in terms of results and talking about what that means and how the patients are managing with those results. So yeah, quickly through that. If anybody has any thoughts initially about that, then pop your hand up. If not, I'll move on. Kasia?
Yes, very briefly. This is exactly again the place where I feel, and I know that Joe and Lauren agree with me on that. That we can really make a huge difference again if we work together within the region with education, with empowering all members of our team to basically help and come along, because I cannot see why the midwives would not be consenting for this test.
And Jess?
I'm so pleased to hear that, Katia, and I would welcome that here. But at present, as Lauren experienced firsthand, we have not got that picture of engagement and confidence and support for midwives during our 21 consenting here. So if there's so many regional and local issues that we can, if we work together, I think we can be more powerful to get a consensus across. Because my first question when I look at that is, what is our gold standard? Like, what are we, if we can say as a group, a working group, what it is we're trying to achieve in terms of who's doing consent, then I have more power to help to start to implement that locally. But those are the sorts of things we could be quite powerful about from my perspective. Because at the moment I can't tell them what it is that we're trying, what is best practice. Yeah.
Do any of the midwives from Norfolk and Norwich or Nottingham have any thoughts on if they were to be asked to do consenting for alternative one? Sarah? Sarah Logan? Got your hand up, I think.
I'm not from the trust that you were asking about. I'm from North West Anglia, and I'm quite new into the role. So I was just wondering, is there anywhere that you would recommend me in a way of getting some more experience with R21? We've done it very infrequently here at Peterborough, and it's at Hinchinbrook, sorry. And I think the consultants kind of handle it. But is there any way that anybody could recommend getting more experience in doing this so that we could take it on as part of the midwives role?
We can work within the region on that and see what would be best ways to actually, once we've got this data, which is clearly showing that the midwives' input in terms of R21 and consenting is less than potentially it could be. I do feel strongly could be. Then we can work together in making some recommendations and training. First of all, training and making midwives empowered and confident in counseling and consenting patients. So yes, absolutely. I think that's the work for the region.
Okay, great. Thank you.
Fetal care?
So I think we would mirror that in terms of empowerment and confidence in midwives consenting, and also time constraints are a big issue here as well, in terms of the sheer volume of patients. So I think there's some work that needs to be done. We're certainly not against it, but as I've said, other people have agreed it's about empowerment and confidence as well, for us to know that, one, we're doing it correctly, having the correct training to do that, and yeah, and time is a big issue as well.
And time to do the training as well, but it would be good.
Okay, thank you.
It seems to me that the thing is happening already, and of course that's not the best way to, we're already sort of chasing our own tails, aren't we? But on the other hand, those people are already doing it. If we think we need some data, however boring that sounds, to show that it's working well with midwives doing it, and then we can say, okay, midwives need to be involved, and then we can talk about resource and how to actually implement training, you know, so it's all to do with showing it's working well. So Fleur, no, I'm joking, but you know, like I think that's in the end, that's how we move things forward. We need to move things forward. If anyone can give us, because we can say we want them involved, but then they'll say, how do you know? Potentially.
I think Sarah Bennett had a comment.
Yeah, thank you. Just really quickly, it'd be really helpful. I mean, somebody just mentioned sharing of data, but it would be really helpful if we could have the slides from this afterwards, because even this just gives midwives confidence. Actually, we're not overstepping boundaries, and you know that is part of our role. So knowing that other regions are doing, you know, already providing that consent. So it'd be really helpful if that's possible, please.
Okay. Yep.
Lauren, I was just going to say, Kirsty's made a really good point as well in the chat about consultants having the confidence in the midwife's ability to gain consent. And I think sometimes that is one of the big issues, isn't it, is to get that support and guidance from them to get involved.
Yeah, I agree. Oops, sorry, Fleur, you had your hand up. Or you're mute.
I think also it's down to the consultants being confident in R21. It always starts from the top, and if they're confident in it, they can share that. You know, so it's education across the whole board.
Yeah. I'm going to fly through these because, again, we've talked and it's been so interesting to talk. So I'm going to, the MDT format is very different across different units. So some sort of standardization around that would be really useful. Again, would probably help to address some of these issues that we're experiencing in terms of how midwives and consultants and those sort of nuances. But I'm not going to spend too much time on this because there's more interesting things to talk about. So requirement for R21 specific education resources was something that came up. And so we are doing an East Genomics R21 e-learning resource, and that should be hopefully ready September, October time. And R21, we are doing a lunch and learn in September. So watch this space for invites for that. Talking about patient and family support. So this is an area where I kind of just popped what people are doing on a slide, but it varies within region, and I know that it's not by any means perfect, and there are issues in terms of commissioning and funding. And I feel that if we could get more kind of an understanding about what people feel the steer needs to be on this and how we can help with that, then perhaps now is a good time to revisit it in terms of commissioning, etc. So I know we haven't got much time and we may be running over, but does anybody have sort of any good practice or thoughts about, you know, what we think needs to happen in able to be able to support these families through this really tricky process? Jess?
I'm really sorry. I'm not going to say much. I'm going to say yes, but there's about 3 hours we could talk about that for. There's so many things we need to do for patients following up. We need a whole, you know, we need a whole session just to cover that.
Yeah, like a whole chunk of work. Yeah.
I mean, I don't know if you have the figures, but I imagine it's very different in each centre.
It is very different.
And I reckon it's probably piecemeal. Certainly is here.
I think so. And I think that in a way it needs its own project and own questionnaire where we really drill down into it, because I don't know if we got as much information from our questionnaires as actually would have been sort of as useful as we needed to be, but it you know, it still gave us a pulse on what's happening, and there is some really good practice there, and people are definitely doing the best they can. But again, we've got time constraints, staffing constraints, and so yeah, it's a bit of a push and a pull, I feel. But at the end of the day, we need to really think about what is best for the patients. I'll move on, but we're probably going to revisit this at some point. So the patient information leaflet working group, anybody want to help write this patient information leaflet? Really would appreciate your help and support with it. Probably going to start doing that shortly, hopefully. The patient feedback in fetal medicine, Nottingham do the only unit that they have sort of a pre-existing fetal medicine feedback mechanism, and they've done it through the Friends and Family NHS questionnaire, which is awesome. Bye, Jess. And they have, so what we're doing is 2 pilot sites at Cambridge and at Eastern North Herts, one's a tertiary and one's a secondary centre, to implement this and see how it's implemented and how that actually process works and if it's straightforward. And then we would share with the group how to do that. And hopefully other units will be happy to sort of look to implement that locally for themselves. It's quite a straightforward questionnaire. It's not too in-depth. It's not hopefully too difficult for people that's coming through a fetal medicine appointment to fill out, or particularly triggering in that. So I think that's a start. And it's something that's already embedded within the NHS, so it kind of gets through some of the loopholes that you would have to normally go through to get sort of patient feedback in place. We're hopefully having a genomics fetal medicine network. Joe is working hard to set something up. So a lot of the stuff that we talked about today, all the challenges, etc., we really want to be able to collaboratively work with peer support across professionals, with consultants, learning together about best practice. And as things change, keep pushing those boundaries, keep working really hard to develop services to be the best that they can be for patients. So watch this space. Hopefully that will come soon-ish. She's working hard on that now. So we will let you know once that's up and running, and we'll send invites out. So how you can get involved, I've kind of already touched on it, but just to remind you, give me a shout if you want to help me with the leaflet. Clinical Pathway Initiative for R21, that's a useful document about how we standardise the R21 testing, and that goes on to the Genomics England. Was it Genomics Education? Joe, remind me. Goes on to.
Oh, well, it's changed now because it used to be Health Education England, so I think it's now NHS. Oh, Vicky knows it. I can tell by the look on her face she knows it.
Sorry, say that again, Joe. What was it?
Health Education England. They've moved over to, is it NHS Education or something now?
Oh yeah,
I'm not sure if it's completely.
I don't think
defined.
they're completely sure of their new title yet, but it's
But what was
it's NHS England, and then
what was Health
within
Education
that.
England?
So there isn't a pathway yet, but there could be, and so I've sort of started that initial process of getting sort of the agreements to put that in place. So I am putting together a working group so that we can develop that and then get that standardized, and then that would, I imagine, go across the whole of the UK. And then looking at the workflows that I've already shown you, so having some input with those. I just really appreciate anybody that had any amount of time to spend on that, just to give me some feedback and work with that. And then you can come and join the Lunch and Learn session in September and join the network once it's up and running. And then any questions if we have any time, which I don't think we do, but if people have time to stay, I do. So I'm not in a rush.
Yes, please get involved and help with this outputs. Quite a few very good points came out from today's session, which we will work on, and produce the output which could be used to get more resources and reshape our units to best serve for the patients and help us working.
Yeah. And thank you all for your time today. I really appreciate it. I know we're under a lot of strain at the moment, so anytime that you're able to give to this, and if you come away from this and you haven't got any questions now, but do feel free just to drop me a line if there is anything that you thought about. Thank you so much for actually all your input as well. It's been really helpful to see different perspectives. Thank you.